Well, good morning and good afternoon, depending on where you are. My name is George Harston, and I would like to welcome you to the AHA webinar. And the title of this session is From Detection to Treatment, Stroke Technology That's Changing Lives. By way of introduction, I'm just going to give a bit of background on how we're going to run the discussion today, and then I'll ask each of the panelists to introduce themselves in turn. So my name's George. I'm a practicing stroke physician in Oxford in the UK, but I spend most of my time as Chief Medical and Innovation Officer at Brainomix. And Brainomix is an AI imaging software company, and our flagship software is Brainomix 360 Stroke, which is used to support decision making for treatment in acute stroke. And one of the challenges that I experience in my role, and I'm sure we'll come across through the discussion today in other areas within the stroke field, is thinking about how we drive clinical adoption of innovation. As without adoption, you can't have a positive patient impact and you can't improve the lives of patients, which is, why we're all in this business in the first place. So we operate as a company in about 500 hospitals globally and come across many different challenges around adoption and particularly sustained adoption. And it's a big area of focus for us as a company. I know other people in the space as well. And I hope to dive into this in a bit more detail with our expert panelists today. I'm delighted that our panelists today who've joined us provide a range of experiences and expertise, and we have some innovations which are medical, sort of traditional medtech devices, a sort of a physical device. We have software, and we have direct to patient sort of products and innovations, as well as those which are supervised by medical practitioners. But what our panel do have in common is an intimate involvement with driving adoption in stroke patient care, with the worthy aim of improving patients' lives. Just by way of housekeeping, before we start the introductions, there's no slides in this webinar. It's a discussion. It's a panel discussion, and we're going to try and keep the contributions from the panelists focused so that we can cover a broad range of topics, or as broad a range as possible. And we won't be taking questions during the discussion, but I'm really keen that if anyone would like to join the conversation and ask any questions or make any points that they want to share, to use the Q&A function in the Zoom meeting, so that we can tackle those at the end. And I want to leave plenty of time to make sure that we hear the questions from the audience and can address any points that are made. So with that, I'd like to ask our panel to introduce themselves in turn. And they're also, I've asked them to briefly explain sort of what area they work in the sort of stroke innovation space, and then we'll start the discussion proper. So in the order of appearance on my screen, at least, if I could ask Teresa to introduce yourself first and give your background.
Thanks so much, George, and thanks for the invitation. My name is Teresa Jacobson Kimberly. I am a professor in the physical therapy department in the School of Health and Rehabilitation Science at the MGH Institute for Health Professions, which is part of the Mass General Brigham system in Boston, Mass. So I'm an academic scientist, researcher in the area of neuroplasticity and neurorecovery. I am particularly interested in neuromodulatory interventions that pair with rehabilitation to help facilitate recovery outside of the acute phase, but really once somebody has their stroke and they have their deficits, how do we maximize that improvement?
Fantastic. Thank you very much. And moving on, Vera.
Hi, thanks for having me here. Really excited to have this discussion. I'm Veera Ananta, and I'm based in the Boston area as well. And I'm currently focused on the company I run, Constant Therapy, which is really focused on enabling patients to be able to receive speech therapy, cognitive therapy at home, beyond the time they spend in the clinic, to be able to really amplify the care that they really need, especially in the chronic phase of their journey, especially after a stroke. My background is really in the technology space. in health tech as well as in other areas of technology, building AI systems as well as software systems at scale, delivering it to in constant therapy case to patients at scale. We also are able to we also are working with as by way of background with constant therapy. The program is used widely across hospitals, across the continuum of care, inpatient, outpatient, home health, etc. So we are very familiar with the process of adoption and the challenges associated with that with technology solutions. Looking forward to the
Fantastic.
discussion.
Thank you very much, and quite a complimentary perspective. So that's great. And last but not least, Reza, would you like to introduce yourself, please?
Yeah, truly an honor to be here, part of the panel. So my name is Raisa. My background is in social psychology, digital innovation. I nowadays, my specialty is around the product strategy and passion for serious gaming in product strategy. So my work at Healing Hand Tech, we are focused on delivering like delivering the fully remote but like high quality care to patients. In this case, this is the upper limb rehabilitation after stroke. And our work focus my work particularly focuses on how we can make the stroke rehabilitation more engaging, as I focus my approach to building to healthcare in general, and health innovation is about building experiences more engaging, measurable, and accessible, which is precisely what the impact is about, through gamified technology, wearable sensors, and clinician-led remote care.
Fantastic. Thank you for your introductions, and really pleased, to find the really complementary, I guess, experiences and backgrounds. I'm guessing, Teresa, if I could start with you, that sort of gaming probably isn't a massive part of sort of vagal nerve stimulation, but I just wondered if you'd share some of your thoughts about some of the challenges you faced when thinking about clinical adoption of an innovative technology like the one you've been working with.
Yeah, just to give a little context of the technology, why I'm part of this webinar. So I've helped to lead the pilot and pivotal trials associated with paired vagus nerve stimulation for stroke recovery. So the brand name of the device is Vivastim. The company associated with that is Mobia. So in 2001, we had a successful pivotal trial in chronic stroke for upper limb recovery. FDA approval followed shortly thereafter. And so now we've had 6 years of clinical adoption progress to trying to get this implemented. So in terms of challenges, the thing that I think was somewhat surprising to me, which it probably shouldn't have been, given the known literature on how long it takes technology to move into clinical practice, the cited number is 17 years. I guess I was unprepared for how challenging this would be. And I think the thesis that I have witnessed of really the heart of the problem with the implementation is apart from just general change in behavior, which I think is a separate conversation about how hard it is for people to change their practices, in particular related to stroke care, there is I would dare say, a broken system in that people have really exceptional care during their acute hospital stay, where we have a number of innovative technologies that have really helped improve life-saving and disability-reducing impairments. And then they discharge from their acute hospital, and that's where things really go all over the place. The kind of place you discharge to and the care that you get, whether it's a skilled nursing facility or if it's an inpatient rehab hospital, or maybe you discharge to home, is not based on your level of impairment or your needs. It is more based on the kind of insurance you have, the location of the country you're in, et cetera. And the care after that, if you were lucky enough to be in an inpatient hospital, once you leave that sort of network of people who are trained to really deal with patients with stroke, patients tend to just float away into just general healthcare. They don't have a clear specialist who is helping to direct the care for the rest of their life. This is something that we have if you have MS, if you have ALS, if you have Parkinson's disease, if you have any other major neurologic disorder, there is a quarterback who is helping direct your care, and you're checking in with them, and they understand you, and they are able to then tell you about new potential treatments that you may have, that you may benefit you, that may be appropriate for you. What happens is that the patients with stroke, once they move into that chronic stage, they're maybe being cared for by their primary care provider, who does not necessarily have a specialty in stroke recovery. And so we really see this loudly when we do research trials, when we bring people in, we see how much their care has fallen away. But now that we're working to try to implement Vivistem throughout the country and within my institution as well, that pathway is not well established. The pathway between especially something like an implantable device and rehabilitation in stroke, those pathways are not well known. Like, these people don't even in the same system don't even necessarily know each other. So how do we have, I think the future looking is, how do you have somebody who is in charge of caring for people with stroke, who stays abreast of the different therapies that are potentially available, and then is able to help resource this to the appropriate patients?
It's really interesting that there's a sort of a, even if you've got an innovation, effectively finding the patients who can benefit from that becomes a challenge. I was wondering, listening to you talk, I mean, obviously the device that you've been involved with is a very sort of medically supervised device and regulated. I wondered if, and clearly that lack of a pathway is a real challenge to drive adoption. Do you think, Vera and Reza, do you think some of your technologies that perhaps are more directly accessible by patients, do you think that is addressing some of that unmet need? I mean, Vera, for example, do you find that patients come looking for you because they don't get the specialist input they need?
Yeah, and just building upon what Teresa was saying, it's completely true that our system is very, very broken. And this is true for many parts of our healthcare system. We see this as consumers, especially true for stroke. And we're extremely good at making sure that patients don't die. But beyond that, it's a lot of ad hoc things that are happening. So for what we are doing, just for context, our program, Constant Therapy, is really enabling patients to be able to get that speech therapy and cognitive therapy at home. It happens independently, I should say. That is, they're able to practice their therapy independently on their own. It happens in a couple of different ways. One is when a patient is in that acute phase, or soon after acute, the initial post-acute phase, where they are getting therapy with their speech therapist or occupational therapist. They don't get enough of it even in those situations. They're getting maybe once a week type of therapy if they're lucky. We live in Boston, and you have a snowstorm and you don't even get that because you have to typically go into the clinic. So what happens is our initial aha moment was even in that phase, it was actually really useful to have something like Constant Therapy to be able to fill in the gaps in care, so that it can make it more continuous in between those visits, and the patient is able to progress more. So the way we have, so that aha moment actually helped us significantly with adoption. So our goal always has been and always was to enable that patient to succeed at home. We at the outset knew that the problem was that patients get discharged, and whether it's from acute care or post-acute care, they get discharged too soon, and they don't really, in their chronic phase, they just aren't getting enough. That's a problem we've always wanted to solve and we're solving. But understanding that this could also be applicable in that in the acute and the when the patient is being seen by the clinicians was really useful because what we the way adoption has happened for constant therapy and it's being used at scale right now. We now have delivered over 750 million exercises through the program. And the reason that has happened is clinicians, such as speech language pathologists and occupational therapists, do use our program to standardize their care in the clinical settings. They use our app. There's a clinical version of the app that's used at places like MGH. And more importantly, when they're using it, they're enabling that patient to be able to do what we would call as homework. That is, they're essentially flipping the script. The patient is actually expected to do all their therapy on their own. The clinician now, when they're using constant therapy, they're using our platform to not do the rote exercises as much as look at what types of issues the patients are having and then giving them strategies. So they're practicing at the top of their license now. So having understanding that the fact that it is useful in that stage has helped us tremendously with adoption because clinicians absolutely love our product. They've adopted it, they're using it. And organizations like Mass General, adopt our enterprise version of our product because of that. And then you have then patients introduced to this by their clinicians, which is one of the ways patients find out about the program, and then they are using it on their own. So it does solve the problem of filling the gap in care that Teresa was talking about, but it's a non-trivial process to get the adoption going. You mentioned the 17-year time window. It's not that far away from that. It's unfortunately, even with all the stars aligned, it just takes a long time for adoption. And one last thing I'll say is, for us, adoption actually is not just the clinicians needing to adopt it in the clinical pathways. To serve the mission of why we are working on constant therapy, we really need that patient to use it at home. And we can talk about it maybe at a different segment here. But that is non-trivial as well. That is having people, especially think about a stroke patient who's had a brain injury, and how do you have them engage independently on their own is a whole different set of challenges.
Perfect. And I think that leads us really nicely actually on Reza. It'd be great to get your take on that as a
Yeah,
sort of expert in the
considering
gamification. Yeah.
considering my love for like the general like patient experience that we're building, Vera, that's the couldn't agree more, both with Dr. Kimberly and Vera very much. I would even say that it's not just not having the mechanism to actually deliver the long-term care without treating it as a chaotic, like a chaotic puzzle of episodes of care. But even more than that, when there is a mechanism, for example, transitional care management or remote therapeutic monitoring, it is so like slowly introduced and poorly adopted when you all like with the mechanism that you already have, that so like it's doesn't solve the problem as much as it could possibly solve. But the dealing with the patients is extremely difficult, especially when it comes to stroke and in general neurorehabilitation, of course. But when you are for the medical devices, like for the medical solutions, such as, for example, like a healing hand and constant therapy, it is about that's it. You are face to face alone with the patient. No one is monitoring. No one is there to do the external motivation. And that's precisely it. So you are building the medical device not as a solution or not as a service. You are building it as an experience that the therapist needs to value and needs to be able to measure. that the provider and the payer needs to be able to afford and to be able to fit into the experience that they already have, however messy it is. And the patient, well, first of all, it's good that in kind of that now in the last years, finally, healthcare industry understood that the patients are living beings with their own opinions, and that if you start investing and caring about long-term adherence and asking for patients' opinion, heavens won't fall, and it actually brings you incredible results. So. Yeah, I guess what I also like, Vera, what you said about like filling in the gaps. I think starting to fill in the gaps is like a very nice, neat way that the medical technology can get the foot in the door to start transforming the care, because obviously you cannot jump from kind of chaotic, like barely, you will get lucky if you get any kind of rehabilitation sort of experience, up to every patient gets every patient that needs upper limb rehabilitation gets 2 hours of daily exercises, like by default. And it's so like right after you get discharged from the acute care. So it doesn't happen over time. And this kind of starting to adjusting yourself to start at the very least to start filling in the gaps in the where you can is where you kind of when you can kind of get your foot in the door and then grow. I somehow have a metaphor with the mushroom system in my head, if I could offer it. But yeah, so it's all about caring about the experience of those who will be using it, I guess. But I mean, of course,
Yeah.
psychologists will be saying so.
No, I think that's true, and I think it's I think the user experience, whether that's patients or clinicians, is obviously critical, and the clinician perspective. We might touch on that in a moment, but I think it's really interesting what you've all shared is the importance of having a pathway or a structure to sort of maximize really the adoption of an innovation, and also interesting, I guess, just reflecting on what you've all said, is that yes, an innovation can add additional benefit to a patient, but actually it sounds like the adoption of an innovation creates more structure as well in a chaotic and unregulated system. So I guess there's a sort of twin value from the innovations there. I think what would be really interesting to reflect on is that last point around the patient experience, Reza, that you talked on the importance of that. But also, I guess the clinician experience and the clinician expectations and thoughts around your device and the sort of relative roles of that. And I don't know, Vera, if this is something that you've thought much about, but actually the balance of the sort of patient engagement and the physician, I guess, validation, approval of your technology.
No, we've thought a lot about it, and just building on what was said before, the user experience. It's one of the things we found as we built constant therapy, and with my background prior to this, you have all these user experience studies. You do various things to make sure that you're building something that's targeted for your to achieve adoption. When you're working with the kind of patients like we are working with, stroke patients, a lot of those assumptions, a lot of those playbooks sort of go out of the window. So the way we've been able to achieve the user experience is literally having the engineers, myself, everybody literally actually watching patients, caregivers, and clinicians, like you would do in a user experience study, but not just outsourcing it to somebody else, but internalizing it ourselves completely. I'll give a couple of an example of that. For example, with stroke, for example, many patients will get will have a paralysis on the right side, and as we all know, a lot of people are right-handed. So when you design the user experience, one of the things we didn't we had all the action buttons initially in the right hand side, and patients were clinicians we would actively talk to clinicians and patients, and clinicians would tell us, oh, the patient is getting really tired, answering the questions on your app. And we couldn't, we couldn't comprehend what they were talking about because it was just so strange. How could it be that difficult to be pressing buttons on the app? But it turns out that they were taking it very seriously, which is what we wanted. They would be using it for 45 minutes, and we saw many of these sessions, and we got tired watching a patient who had paralysis on the right side, moving their left hand all the way to the right and pressing the action buttons on the right. So from the get-go, we built in things that would not be obvious unless you actually got into internalize this. So we built in something that will allow us to have a right-handed mode and left-handed mode from the get-go. So those kinds of paying attention to the details is really critical, both for the patient side as well as on the clinician side. So we have we have institutionalized this across our company, where we are getting feedback from both stakeholders, if you will, and that literally drives the new features and all the product roadmap for us. We're not just making up stuff; we're just literally listening to the patient or the clinician, and it's an endless list of things that people want, and that really helps to make sure that you have something that fills in the gaps, meets the needs of both the clinicians and the patients.
Fantastic, Vera. It's really interesting, and just goes to show the importance of that user engagement to identify those seemingly obvious things that could be a real completely destroy technology innovation. Teresa, I was wondering to get your thoughts as somebody who's been involved in sort of formal clinical trials to support the adoption and development of the new technology, around the sort of clinician perspective and attitude to innovation, and how that varies, or any challenges you've had around that.
Yeah, that's a great question. And just to build upon what Vera was saying, NIH and funding bodies have done a much better job in the last decade or so to ensure that you have all of the stakeholders involved as you're building the devices, or even in the preclinical stages, and you're starting to think about what should this look like, to really involve those stakeholders. And you do have to bring the clinician stakeholder is an important one as well. And that, the change, change is hard. It's for any of us, but you have somebody who's been treating patients a certain way, for a 15, 20-year successful career. And it's very hard for them to think about, wow, there's some new technology now that might make me have to think differently about how I'm delivering this care. And I think the thing that I think is successful with that is to not downplay the importance of the education, and truly, you can't just shove it down their throat. Look, here's this pivotal trial, and it had these results. You should be doing this. It's from an implementation science perspective, you want to really identify what the barriers are. And one of the things that I found in just talking with other health systems that are implementing Vivistim is that they're not the same. So one center, one area will have a different strategy and barriers than a different one will have. And so you have to really assess within each individual system, what are the barriers? And it's just like Reza and Vera said about talking to the patients about what should the therapy look like. You have to talk to the administrators and the clinicians and all of the people along the way about what are the barriers, and then how do we address those barriers? Is it with information, evidence? Is it with training? Is it with helping marketing materials? Is it with what is the type of intervention that this system needs, because it's not universal?
Yeah, I completely agree that broad stakeholder engagement and listening is really really important, I think, for successful adoption. I think it touches on another point which I think is critical to driving adoption, which is around evidence. And you touched, Teresa, on the sort of communication of the results of a pivotal trial, for example. And I think as clinicians and academics, it's very easy to get into that trap that evidence is, it's a paper from a journal about an independently controlled trial, whatever it is. But I think I guess the evidence that I see that it often drives adoption and the weight that it has can be not necessarily what I'd think it was, even to people who you think are very sort of scientifically rigorous and trained. And actually, just a simple thing like their friend in another institution saying, "Oh, I use this. This is my experience. It was good." The case studies, the even and press coverage as well. Actually, all this evidence I think is has value in different weights. And I don't know if anyone wanted to sort of pick up on that theme. If I don't know, Razor, if you've thought about what types of evidence have different weights with different stakeholders and how you go around using that to drive adoption.
Yeah, the answer to your question, as well as to the previous points that we discussed, so like how to drive adoption and everything. My answer to all of this is usually can be boiled down to one word: personalization. It highly depends on what exactly you cannot predict what kind of patient you get. They are all motivated. It's easier to build personalization into the design. Same about the therapist and the types of facilities you are dealing with. It's easier to implement sustainability and personalization into your design. And same with evidence. You need to keep in mind the different views and different decision-making criteria that they think about. It depends on what it like, depending on the geographic and depending on the demographic profile, patients can think about the financial criteria first and then everything else. It can be and so on. The important part is to you can generate a lot of criteria. If you ask all the different stakeholders, as a result, you will have an endless list of different types of evidence and types of data you can gather. Obviously, so that's like endless clinical trials then you will have in your to-do list. The way to approach this is potential way to approach this, for example, as we do in our company, is to try to take a look and which of these stakeholders you approach on a timeline. Who will be making the first decision about passing it down to the second stakeholder, and so on and so on. What are the types of evidence that they care about? And then you can prioritize them on the matter of timeline. What type of evidence you will need today, what type of evidence you will need tomorrow, and next week, and the week after next. Of course, I'm saying this about prioritizing and identifying them for specifically for your product, or specifically for this or that facility, or this or that type of subcategory of patients, because the long list of types of evidence, we can name all of them. So the safety and the operational benefits and the ability to generate financial outcomes for the rehabilitation facilities, which of course we do, and so on. So all of these matter. It depends on who exactly you are talking to.
Fantastic. I think, that's a really important point, I think, isn't it? It's that, I guess, tailored messaging for different stakeholders, different stories, different bundles of evidence, I guess, speak differently to different individuals. And I think your point
helps you, and that helps you understand how exactly you should build this plan of generating evidence, of course.
Indeed. And going back to the previous point, though, it's really critical to listen first, to understand what it is that people want around adoption. I guess, Vera, I don't know if you want to come in there, but one of the themes I don't know if you would touch on as well is we touched tangentially briefly on a couple of times about reimbursement and payments and stuff. And I guess that is obviously a key driver to a sustainable adoption. I just wonder if you have any thoughts about that, but please, whatever point you were about to make as well.
Yeah, so it's related to the evidence question. So when we started out building our product and building the company, initially our thought was, we got to build all this the pivotal trial with the best evidence before we go to market. So we started on that path. We actually did a initial clinical trial, and we had a product that nobody could access really. You could download it from the App Store, but really couldn't use it. And in that process, so as we were doing the trial, we discovered that people started downloading the program, even though we didn't even have a website. And we started seeing the a need for the patients and their family members wanting to use our product at home, which actually um, drove our decision making in terms of how much evidence to build before we go to release where it was available publicly. And the approach we have taken is, to your point, George, of listening to the various stakeholders. In this case, patients are the most important stakeholder in my mind. Is really building the evidence in a staggered way as we went along, and we now have a lot of evidence. But we think of it in two ways. One is we enable patients and clinicians to have access to the evidence-based protocols and exercises that is very robust, that's available in the program. And then there is the evidence around how does the efficacy look in terms of the use of the entire product with its AI engine built in and so on, which is, the compendium of evidence we've been building up. It's not, as Reza was saying, it's an endless process. You can continue to build evidence for various indications and so on. So we are on that path for stroke, dementia, and so on. And back to your question about reimbursement, depending on where you are in the stage of getting this paid for, um, you need a certain level of evidence. So if you want this to be, so in our case, constant therapy today is not covered by Medicare directly, for example. However, we do have enough evidence to enable clinical adoption in various institutions, whereby the program is actually paid for. If a patient goes to one of the organizations that is using constant therapy, the patient can access the program through them for a period of time where they're getting the plan of care through them, because it helps that organization to actually show improvement, better efficacy, lower cost of clinical care, etc. So it's really the point you were making earlier, George, in terms of you really have to figure out what is that minimum. There's the concept of minimum viable product in
Mm,
technology. It's also a minimum viable evidence so that you can show enough to get adoption, and then that
yes.
helps you fund the next stage of growth and so on and so forth. So that's really the approach that we've taken. In terms of reimbursement, you're absolutely right. If it's covered by insurance in the way we all as consumers think about it, it would be you would be able to have ultimate growth, which is a big unlock in terms of growth. But you can't get there, unfortunately, on day one,
No.
or maybe even in year five. So really you have to, it depends on the specific product, and building the evidence pipeline that is aligned with the goals you're trying to achieve.
Yeah. And I guess the clinical option itself is a form of evidence, as people
Hmm.
touch it and feel it and want to use it more and
Yeah.
continue to use it, that's probably your best, most compelling proof point, isn't it? There's a
Yeah.
there's a really interesting question I'd like to go to in the Q&A. So thank you for those of you that submitted them, and for those of you who haven't, feel free to submit them. If there's a couple of good ones, we can add them in as well. I wanted to take a step back. This is a question that I'll read out. And Teresa, I don't know if you'd like to take this one first as a clinician and an academic who's worked very closely with industry. The question is, how do we translate the clinical and altruistic value of rehabilitation technology into financial outcomes that matter to rehab facilities and health systems? So, paraphrasing, to my mind, it's about how do we align the sort of doing good for patients in a sort of clinical sense with sort of financial drivers of adoption. And I wonder if you'd had any thoughts from your perspective as from your clinical and academic role.
Yeah, I do. I'm afraid it feels a little bleak, honestly. The rehabilitation reimbursement model is not great. And just in the course of my career, lengths of stays in inpatient rehab facilities have dropped markedly. Spinal cord injured patients used to stay in patient rehab for a year, and now they get a few months. And so the kind of care that the pressure on therapists is very different now. They have to really think about their goals more related to, how do I get this patient safe? It's sort of a low bar of function and it's antithesis to what rehabilitation can do, which is really to improve function and biologically support improved brain connections that can then facilitate even greater improvement, et cetera, et cetera. So there is a really big tension in rehabilitation that I think all providers went into this wanting to help people, and now they have these pressures related to financial, the number of billion hours that they have to squeeze into a day, et cetera. And it's tough. I don't have a lot of great advice on this, because what I see is that a lot of times the new innovations are driven sort of by really dedicated providers who just want to see the evidence and want to bring it in and want to make it useful. I think the one sort of silver lining in it potentially is that if systems have awareness, that there is a market opportunity to have good outcomes, build reputational value for having good outcomes, and build reputational value for having innovative care. I think if within the system there can be motivation to bring on new technologies, but ultimately, we're talking about workarounds that Vera and Reza are talking about, because they have companies that they need to make money, which is legit. But the problem is that our whole system is designed around these workarounds, without really addressing the fundamental problem, is that the rehabilitation is not reimbursed in the way that it should be. And there are multiple, especially in the US, the Medicare Advantage plans, people are unaware of the sparse number of therapy sessions that they are allotted. And this really, the American Heart, we wrote a paper on this that came out last year, really highlighting the importance of this problem, and that we have to have some kind of research and public outreach efforts that say this is not okay.
Yeah, absolutely. Sorry, please, Vera, go ahead.
Yeah, and just adding to that, just in terms of practical things we have seen, you're absolutely right. There's policy things, there's advocacy things that American Heart and others can do to change that. That is in the long term. For any entrepreneurs, anybody building companies, obviously that you will die long before any of that comes to fruition, right? So there's things that you have to do, practically speaking, to figure out in your specific space and your specific solution, how do you tie that to outcomes or something that is return on investment for the health system or whoever is you're looking to drive adoption to? And this was mentioned earlier, it could be marketing materials, it could be other things that tie the connect the dots for them. It's not that, so bottom line is the reimbursement for rehabilitation has been going down, and I don't see that changing, but the payment for outcomes is going up. It's a slow process, but it is going up. So somehow, in our case, for example, us realizing that, oh, this actually is helping, the clinician burnout is increasing. We all know that, and that's actually an accelerating trend across, all of healthcare. And us realizing in constant therapy that, oh, this is actually helping the reduction of clinician burnout and attrition, and helping them save time, and using that as a message with health systems and using their peers, like you said, George, earlier, right? That was not clinical evidence as much as their peers telling them, hey, you know what, this is actually saving my time. I'm making the administrative level, they're able to keep their staff. Being able to find those nuggets, and the only way you find it is actually talking to the providers and whoever the stakeholders are. And it's different for different technologies, and it's not always, in fact, most of the time it has nothing to do with clinical evidence.
It's it's a really interesting point, Vera, and I think it's quite a sad point that actually you have to find other ways to justify the value of your technology. I mean, to me, all of the technologies we've discussed today, the value to society is clear, you know, in terms of making people better and what have you. But trying to justify on the grounds of reducing burnout and not having a system that can recognize that broader value is a clearly an unmet need, particularly in the rehabilitation space, from what I've heard. Sorry, yeah,
Um,
raise it. Yeah, please come in.
I was just hoping to bring kind of couple of drops of positivity
Fantastic.
into this view. I mean, of course, ask the psychologist. They will also always be talking about experience. Consider this: you're taking the technology, you're taking the product, some kind of like new thing that you are implementing into the existing experience of the patient, of the caretaker, which is, let us be honest, for example, in some cases, so like with some, in some populations or geographic areas, most of the, so like B2C decision makers will be the caretakers, especially at the like earlier stages. The therapist, the billing manager, and so on and so on. I think it's about the quality metrics. So to transform, uh, transform the impact into the outcomes, like actual measurable, like touching outcomes, which is in the end our financial ones. Uh, I think you need to measure it the right way. In my in my view, and again, I do not come from the healthcare industry originally, so maybe that's like a third party point of view. But still, you in my opinion, the kind of how much administrative burden, how much bureaucracy nightmare time you save per day or per week,
Mm.
how much time, like how many like patients per week, like extra you can cover with the same amount of resource, with the same attention, like attention budget without therapists going crazy, or at least even more burnt out. This is all clinical impact because it is
Yeah.
clinical pathway. It is the clinical workflow. So just if we include everything into it, maybe I'm being way too pragmatic or too naive, depending on how you look at this. But then again, these are all quality metrics.
Yes.
The nuance, though, is to identify the right quality metrics, the one that actually measure the quality and don't, for example, appear to measure quality so that you can look like your value-based care, even though you just like picked up the right metrics for you to look like one, and so on. So you need to measure the quality, and the medical technologies need to think about the clinical workflows as as something that they need to measure the impact on. And in this case, first of all, you will be able, all of our talks about experience, listening to the therapist, which like listening to the clinicians, to the rehabilitation, like actual like providers and actual people who deliver your product or like your device, which we've been repeating times and times again during the last 50 minutes. Once we start measuring this, once we start measuring the impact on the whole clinical workflow, first of all, we will actually like be able to like have a bit more like practical, applied approach to delivering this better experience and to deliver these like better, like more measurable flow,
Fantastic.
more measurable outcomes.
Reza, can I jump in there? That's a really important point, and maybe a positive point to sort of as our sort of final point for discussion is around improving pathways. And one of the things that we've noticed in the acute pathway with stroke eye imaging is the opportunity to not only improve pathways and structure, but also to standardize them, and often the biggest impact is where there's the least resource available, the less specialist places, the less well-resourced healthcare systems. We often see a bigger impact because there's a bigger unmet need. And I just wondered whether we might close on some sort of final thoughts, and one of the questions sort of touched on this as well, about the opportunity for innovation to try and address some healthcare disparities. Clearly not all of them, and clearly it's not a panacea, but I just wanted to think whether your technologies can help address that sort of healthcare inequality in some way. Vera, perhaps I don't know if you want to touch on this.
Yeah. So I mean, I see one of the questions is around rural,
exactly, yeah,
rural populations, and no, it's actually it turns out that so we have a lot of data on this. In fact, there's some data that we have. It's one of the published studies that retrospectively looked at people using constant therapy in rural settings versus urban settings to see what the engagement rates are. And maybe it's not surprising after you look at the data, but the results were that actually the engagement is higher in rural, in among the rural population. And it's probably because there is more access to care in urban scenarios. So there is a huge opportunity. There's we do have a customer success team that helps patients with the program and so on. But we also get a lot of people calling us, telling us how we have changed their lives. That part never gets old. And a recent example of that was related to something like this, where a patient called us to tell us that they were in a rural part of the country, couldn't access care, had a stroke, were misdiagnosed. A neurologist For a neurologist assessment, they would have had to drive like 2 hours. I mean, we sort of take it for granted, those kinds of things in the cities we live in the parts of the country that at least I live in. But those are not things that you take for granted, and it makes a massive difference, just those logistical challenges. And after 2 years, this patient finds constant therapy and was calling us to tell us that they've gotten their law license back and is able to practice. I mean, think about the amount of from a human perspective, what kind of impact that can have. And this is not a very old person, right? So they had young kids, and it's massive impact that you can have especially in reducing disparity in care, especially places like rural healthcare. So we just have to find ways to fit within the plumbing of the ways things are paid for, adoption happens, and so on. And we can. I don't say that negatively. I may have come across that way before, but in reality, that's life. I mean, that's literally how life works, right? We have to find ways to fit within the existing pathways or create new pathways to make this successful.
I mean, that's a really important and very positive message, I think, to start to close on. And I just wanted Teresa, just to ask you as a clinician working with patients in this space, the sort of level of engagement, the appetite, I guess, for innovation, and what you hear from patients around their willingness to take part in trials or their willingness to try new technologies and adopt new innovations.
Yeah, I might have a biased sample in that regard, because people come to me with questions about new technologies, and so the ones that aren't interested stay away, I guess. But I feel like the patients this has evolved a lot thanks to probably the internet and social media and things like that. That people are more and more aware of possibilities out there, and people are learning that they need to advocate for themselves within the healthcare system, that they not just blindly trusting a provider to just passively give them all the information. People are more empowered to engage family members to help, or to engage people to help find what are the what are the innovations that I should be aware of? And I think that that is a really positive aspect too about where we're at in terms of technology, that there is places where people can find out about what are the available treatment options. I think the thing that we need to put some guardrails on, or to put some parameters on, is how do we figure out who is a good candidate for something, and how do we prevent some of the devices out there that have no evidence of benefit and that are maybe just going to try to take some people's money for the, so a given device that maybe sounds a lot like an efficacious device. How do we have a better chance of screening those out for patients who may be a vulnerable population, so that there is some sort of way, maybe it's American Heart, maybe it's a local rehab hospital, something where there's resources where somebody is filtering through, these are recommended resources to check out. Somebody who can help people make decisions so that they're not sending $5,000 off for a brain stimulator that they can stick on their head and will magically rewire their brain or something like that. There's a lot of outrageous claims out there that I think are preying on potentially a vulnerable population.
It's an important point, and I guess I'm aware we're getting close to the top of the hour, so I think we probably have to start to wrap up now. But I think it's been a really nice point to finish on, important point to finish on, and I think I'm just reflecting on some of the areas we've touched on during the course of this discussion, and I think it's been really interesting to think and reflect on the need for a patient pathway, understanding what the pathway is and that structure in order to maximize clinical adoption, the opportunity for technology not only to improve, to add its own benefit, but to improve the structure of delivery of healthcare. We've spoken about the importance of the user experience, both for patients and clinicians, and how that translates to advocacy, and how that can then generate its own evidence to drive clinical adoption. We've talked a bit about stakeholder engagement, making sure that we address all stakeholders that are involved in the patient pathway, and how important it is not only to engage them, but to listen and to really understand and observe and identify what the problems and challenges are. And really it stuck with me Vera's example about what side of the screen they had the buttons for their patient engagement, and the lessons like that. And then I think more formally, we touched on evidence and what that can look like, and the wealth of evidence that you can have, and also the way it needs to be personalized, which I think was Reza made an excellent point on how we tailor our evidence depending on the stakeholders, and to make sure that people get the information they want, but also the need to actually just put stuff out there in order to generate more evidence, and actually have a concept of minimum viable evidence, which I thought was a really nice thought, which then allows you to generate more evidence. We also touched on reimbursement and the importance of having systems that can recognize value to society, but also some really interesting points around what value means. So not only about value to society, but also value to healthcare systems, the efficiency with which they run, and how that can translate into better clinical services and better outcomes for patients if healthcare providers are less burnt out or have more time to focus on delivery of care. And then I thought really importantly to finish on that thought around patient engagement and appetite, and the positive impact that these innovations have on individual people, and that everyone has their own story and their own circumstances, and really nice to have a tangible example of somebody who was able to return to law practice as a result of engaging with an innovation. So really fantastic point to close on, but just with that warning at the end that we do still need to have systems to supervise and vet and ensure that people are getting technology and innovation that really does add value, rather than just being technology trying to generate income, but actually improves patient outcomes, which I guess then takes us back to the title of the webinar, which is as we started off, which is about using stroke technology to change patients' lives. And it's been really fascinating to hear some thoughts around how different innovations are doing that today. So Thank you so much to our panelists. I really appreciate your contributions. It's been a fascinating discussion, and grateful for your time. And also thank you to the AHA for hosting this webinar. I think it's been an excellent session, and I hope that this is the first of many webinars in the field of stroke and stroke innovation. So thank you very much.
Great summary,
Everyone.
George. Thanks.